Hello, everyone, and welcome to our webinar, Humanizing Your Enabling Services Data for Patient Care, Overview of the Issues. My name is Danielle Rahajasan, and I am the Administrative Coordinator here at the National Center for Medical Legal Partnership. I will be running technical assistance for this webinar. In just a moment, I will turn this presentation over to our panelists for further introduction. But before that, I have a few small housekeeping things I would like to run through with everyone. Everyone joined in muted and will remain so throughout the webinar. And to ask questions during the office hours at the end, please don't forget to unmute yourselves. On your sidebar of this platform, you should all see a list of drop-down options, space entitled questions. If throughout the webinar you have questions, please type and send it in that space to everyone. There will also be a very brief survey that will launch at the end of this webinar. Your participation in the survey is greatly appreciated. It'll take about 2-3 minutes to complete. And last but not least, if we encounter technical difficulties on our end or yours, please don't worry. The audio is available to all registered participants after the webinar concludes. And without further ado, I will now pass it on to Darlene. Darlene?
Great. Thank you so much, Danielle. And good afternoon, everyone. We'd like to just thank you once again for joining us. And this, we'd like to just tell you a little bit about the 2020 Social Determinants of Health Academy. These learning collaboratives that we're going to be starting or have started, this is the first session of our learning collaboratives, are looking to target the audiences in health centers, primary care associations, as well as the health center controlled networks. So if you have any of your colleagues that you know of within health centers and these other communities, please invite them to register for our learning collaboratives. Each learning collaborative includes 2 90-minute sessions, and we are offering a 60-minute training and then followed by 30 minutes of office hours. And during the office hours, this will give you an opportunity to ask questions and get clarification and really get an opportunity to drill down on some of the information that you have heard in the session. There's a registration, and you can use the link at the end of this presentation. And I'll try to put it also in the chat box so that if you haven't registered for the upcoming sessions, you'll have an opportunity to do that. And as Danielle mentioned, all the trainings are being recorded and they will be available to you at the end of the SDOH on the SDOH website. This is the SDOH Academy faculty, so we are bringing you the whole series, the Learning Collaboratives, is being sponsored or being led by a steering committee, and there's actually 16 national training and technical assistance partners, and you see the logos here that are sponsoring and will serve as a faculty. You'll have an opportunity to hear from all these faculty members over the course of the next 4 months. Next slide, please. So this gives you the topics that we'll be addressing. For the next 2 sessions, we will be focusing on humanizing your enabling services data for patient care. And then the next 2 sessions will come up in March. They'll be focusing on fostering a healthcare workforce able to address current and emerging needs. And then the 3rd session will be reducing health disparities through community partners. And the 4th is equitable preparedness for vulnerable populations. Again, each of these learning collaboratives are 2 sessions with office hours. The first session will give you an overview of the issues, and then the second session will be a deep dive and able to really focus on the mechanics of the topic area. So we're inviting you to register for as many as you'd like and to join us in these upcoming learning collaboratives. Next slide, please. So we would like to really focus on some core competencies during this series. And this kind of gives you an overview of what we would like to accomplish once you are participating or as you participate in this whole learning collaborative series. The core competencies are really to improve access to quality healthcare and services. The next core competency that we're hoping to ensure that people get as they participate in this Learning Collaborative series is to foster a healthcare workforce able to address current and emerging issues, to enhance population health and address health disparities through community partnerships. And then finally, one of the additional core competencies is to help you understand the emerging issues. So again, as you participate in all these learning collaboratives, these are core competencies that you will see all of us focusing on. Next slide, please. I'd like to introduce you to our presenters for this session. And I'm going to switch over to the next slide, which so you can see our faces. We have for our presenters Jolie, who is with the AAPCHO, and I'm going to, here it is. I missed my script, so I had to turn to that page. Sorry, Joe. But for one of our speakers, let me go in order so that you will not be confused with how we're doing this. I'm Darlene Jenkins, and I'm with the Senior Director of Programs with the National Healthcare for the Homeless Council. Then our next speaker will be Michelle Jester, and Michelle is with she's the Deputy Director of Research for the National Association of Community Health Centers. And then our next speaker, it will be Kristina Wharton, who is with Health Outreach Partners. And then following Kristina will be Jolie, who is the Training and Technical Assistance Director from the Association of Asian Pacific Community Health Organizations. And then finally, to kind of really summarize everything, will be Cindy Selmi, who is the Executive Director for Health Outreach Partners. And we want to give special recognition to Albert Ayson, who is not with us today, but he really contributed greatly to this presentation. And Albert is also with the Association of Asian Pacific Community Health Organizations. So this is the faculty that will be presenting today. Next slide, please. So for today's webinar, we really want to focus on, so we had an overview of the 4 competencies that this series, the Learning Collaborative series, is going to be focusing on. But today, our main learning objective is really focusing on improving access. And so these are the learning objectives that will help the participants, or those of you who are joining our webinar, to focus on how to increase access. So the learning objectives is really to increase your understanding of how to build capacity around enabling services to address the social determinants of health. We're going to discuss health information technology, the needs for gathering social determinants of health and enabling services data collection. And then also we'll be explaining the importance of the application of enabling service data for social determinants of health through clinical quality improvement and patient-centered medical home initiatives, as well as value-based healthcare transformation. So with that, just wanted to, before I go, we turn it back over to our first presenter, I just want to remind you that at the end of this presentation, there will be a brief evaluation. So please complete the evaluation. This helps us to adjust because this will be a 2-part series. We'll be able to adjust accordingly. So please complete the survey that launches immediately and give us feedback so that we can adjust accordingly. And I think with that, I will turn it over to our next speaker, Michelle Jester, who will talk about enabling services to address the social determinants of health. Michelle?
Great. Thank you so much, Darlene. We can go ahead and move to the next slide. Great. So as Darlene mentioned and provided a great overview on, this year's Social Determinants of Health Academy is really focusing on addressing social determinants of health and what those core competencies and capacities are needed to really address the social determinants of health. But you really can't focus on addressing social determinants of health without first documenting the social needs of your population. So while this webinar is not focusing on the documentation of social risk data, it is important to open it up to discuss the importance of doing this work. So many of you are likely already focused on collecting data or understanding the social needs of your population, whether that's You know about it through communicating with your patients. You may know about it anecdotally. But we think it's really important to have standardized data on the social needs of your population because it can really help systematize and streamline this work into your workflow. So having standardized data on the social needs of your population makes it much easier to be able to aggregate that data to a population level and then analyze that data to really better understand what are the needs of your population, what trends are you seeing across your population, and where are there possibilities for you as an organization to act both internally with your enabling services or non-clinical staff and your larger care team, or outside of your organization through cross-sector partnerships. So we think that having the standardized data on the social needs of your population is also just really helpful to demonstrate the value of health centers and the health center model, because we need to really demonstrate just how complex our patients are, but then how the health center model is really attuned to that and is built to help address the needs of vulnerable populations. So next slide, please. So we think social determinants of health data is important and useful at many levels. So at the individual level, if you have standardized data on your social needs of your patient, you can better understand the circumstances that they're living in, what might be challenges that they're facing day in and day out that might prevent them from being able to make the healthiest choices possible for them or access resources to help them live healthier lives. So that can really help inform the care and the treatment plan for individual patients. So for example, you may not want to prescribe an individual patient a medication that requires refrigeration if you find out that they're homeless, or they might be living somewhere but they're having trouble with their utilities such that their electricity gets cut off and so they don't have refrigeration. Things like that. So having this data can really be used at the point of care to inform care and treatment plans. At a larger organizational level, once you have a better understanding of the needs of your population, you can really strategically think about how would you want to design your care teams to better manage your patient and your population needs. For example, do you need more non-clinical staff or community health workers to help address the needs of your population? At a larger system and community level, it can really help you think through those cross-sector partnerships. So if you realize that transportation is a large need in your population, then that can really help inform your next steps to informing partnerships with, Uber, Lyft, the transportation sector in your local community. It can think about advocacy for additional bus routes to additional areas to provide greater access to those services. And then finally, at a payer and policy level, again, we really hope that having data on your social risk of your population can help inform more sustainable payment models and also help move the needle to advocate for payment models that incentivize work that goes upstream or work that focuses on addressing the non-clinical risks. So again, the social risk can help paint a picture of just how complex health center patients are, and then having data on enabling services can then really demonstrate just what is needed to take care of a complex patient, but then therefore we need different types of payment systems to make this work sustainable. Next slide, please. So we quickly just wanted to let you know of a tool that is out there to help you collect standardized data on the social determinants of health, and that tool is called Prepare. So Prepare was developed about 6 years ago by the National Association of Community Health Centers, the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association, working very closely with a group of stakeholders from the health center community to develop a national standardized social risk assessment tool that is built into the electronic health record and that is really designed to engage patients in assessing and addressing their social needs. So it's meant to be a customizable tool that can fit into health centers' different workflows. It is built into the electronic health record system to make it easy to be able to collect that data. And it really advocates for an empathic inquiry or a patient-centered approach, that we really hope that this is a tool that can be used to build relationships with patients, better understand them, and then work together to best address their needs. Next slide. So this is not a webinar on Prepare, so I'm only going to have just 2 slides just to give you a brief overview. But if you're interested in learning more, please feel free to find more information at our website at nac.org/prepare, which you see on the screen. But this just gives you an overall sense of what kind of social determinant of health information is collected by Prepare. And it may seem like a lot at first, but I do want to point out that on the left, you see the first 9 domains are all from UDS. So the Prepare EHR templates will map to your practice management system or will map to your demographic information, and will pull that information into the Prepare template, so you don't need to ask those questions again. We know that's burdensome for you guys, and it's also not very patient-centered to ask the same question multiple times. So we've worked with the vendors to map that, so you don't have to ask those again. So in reality, it's really only about 6 to 7 core questions that we think it's really important for all health centers to have a good understanding of their patient's socioeconomic circumstances in relation to education, employment, material security, social isolation, stress, transportation, and housing stability. We also worked with our stakeholder advisory group who suggested that we have some additional optional questions that weren't necessarily required, but they may be of relevance to many communities out there. So we also have questions in relation to incarceration history, safety, domestic violence, and refugee status. Next slide. So I just wanted to point out some resources we have on Prepare that you're welcome to check out, and always feel free to reach out to either myself or Joe at AAPCHO or Albert at AAPCHO as well. Happy to answer any questions you may have. But we have a free Prepare Implementation and Action Toolkit, which really helps walk you through the steps that you would need to take to implement Prepare in your setting, how you can engage patients, how you can talk about this with staff and with your leadership, workflows that you can use, and then how you can use the data to really respond to needs. We have the free EHR templates that you can see listed on the screen. So we have them for Cerner, eClinicalWorks, Epic, GE Centricity, Greenway Entergy, NextGen, and then Athena is very, very soon to be released, hopefully within the next month or so. We have Prepare readiness assessments to help you strategize where you guys are, what strengths you may have in being ready to implement this, and where you might have some gaps that you might want to think about and strategically think about how to build readiness in those areas. We have several recorded webinars on Prepare in the workflows, the electronic health record templates, some of the research and data analysis we've done with the data, some work we've been doing around risk stratification and incorporating Prepare social risk data into risk stratification models, and how you can respond with interventions. We also have case studies and user stories to highlight how health centers have been using Prepare in innovative ways and with different special populations. And finally, we also have several translations of Prepare where we used both a vetted translation company, but then also had communities kind of review the translations to make sure they were culturally appropriate and relevant. So we have 10 translations currently, and we will soon have 16 more to be released in the next month or so. So stay tuned for that. Next slide, please. So in addition to having standardized data on your patient's social needs, it's also very important, it's critically important that you're also documenting what you are doing to address the social risk. Not only will this really help in determining and evaluating, which services tend to seem to be working the best with your population to address this social need and allow you to kind of adjust as needed. But again, it also really helps build that evidence base that we can take to payers, that we can take to policymakers, that our patients have these social needs. They are complex in not only these clinical ways, but also these non-clinical ways. But here's what we're doing to help them. But again, a lot of the non-clinical enabling services that you guys are providing aren't reimbursable under most payment models. And so we really want to build this evidence base to advocate that those services, that those integrated care models, those cross-sector partnerships, really get reimbursed and paid for in an equitable way. Next slide. So we believe that the PREPARE social determinants of health data and the enabling services data that health outreach partners and AAPCHO will go into in a deep dive just here in a minute really go hand in hand, because on the one hand, PREPARE can really help you paint the picture of your patients, and then on the other hand, the Enabling Services Accountability Project can really help you in telling your story about how you're really working with your community and addressing their needs. And we think these are both critically important to demonstrate the value of health centers. So with that, I'm going to turn it over to my colleague at Health Outreach Partners, Kristina Wharton.
Thank you so much, Michelle. I really appreciate that. And I really appreciate your lead of using data to demonstrate the value of the health center model and health centers, how they are providing different enabling services and have been historically as a way to meet that comprehensive healthcare requirement, program requirement for health centers. So we just want to kind of do a little high-level overview of exactly what we're talking about with enabling services. So we're referring to non-clinical services that are provided to health center patients that promote, support, and assist the delivery of healthcare and facilitate access to quality patient care. And we do that in a variety of ways, as you all know, at your health centers. Different types of enabling services categories include case management and assessment, case management for treatment and facilitation through referrals or financial counseling, eligibility assistance for insurance or Medicaid eligibility, for example, or other benefits like SNAP, health education, supportive counseling, interpretation and language services, outreach and transportation, which is what we assist health centers with a lot at Health Outreach Partners over here. So just to kind of make sure that we're all on the same page about what we're talking about with enabling services and why it's important, I also want to thank Michelle for mentioning that it is important to collect data to advocate for what health centers are doing, because we know you all are really engaged in a lot of these different kinds of enabling services, and they're kinds of activities and kinds of staff who aren't necessarily reimbursed in the traditional models of care that reimburse more clinical oriented services. So we also know that one really great way to advocate for health center activities is through the UDS, the Uniform Data System, which is how health centers report data back to HRSA, to their huge funder, through the Bureau of Primary Healthcare. And we are really excited to show how the UDS, as you all know, especially this time of year, I know you're all in the reporting period, that UDS is growing and collecting more and more data related to enabling services, which is really exciting. It presents an opportunity for health centers to really demonstrate and document the ways in which they're doing these different activities, and potentially find ways to find more funding and that kind of thing, and make the case for themselves and to keep doing these different activities that help reach patients. So just quickly, ways in which the UDS reflect these kinds of data that might be collected through a tool like PREPARE. In staffing, so the two traditional tables are the staffing utilization table 5 and financial costs in table 8A, that always were documenting number of FTEs and visits by these different types of enabling services, such as case managers, health education and community outreach, transportation, eligibility assistance, interpretation, the traditional enabling services areas. And some ways that are a little bit more new, which are exciting, is that with the onset of the ICD-10 codes, these Z codes that collect data on SDOH, some of those Z codes are being incorporated into the different codes that are collected through EHR systems for Table 6A for the selected services rendered for various different diagnoses, such as HIV, the overweight and obesity measures, mammograms, PAP, and cervical screening, some contraceptive management categories and screenings. So these are growing in their use and showing up in the UDS that way. And also in Table 7, in the health outcomes and disparities, there's some new data collection there here in the enabling services, other program related services related to health outcomes and disparities. So these are exciting changes and opportunities. And just quickly, what these tables look like in UDS, I'm sure you all are painfully aware. I'm going through some of, if you're involved in UDS reporting at all, at least painfully aware of what these tables look like. Quickly, this is a non-exhaustive list of some of the Z codes, but if you're not familiar, they're an opportunity for which was not available in ICD-9 the previous iteration, to actually code different social determinants and patient needs, as you see in this example, like housing insecurity, food insecurity, transportation difficulties, if the person's experiencing interpersonal violence or economic difficulties. We all know, as working with health centers, that these things really impact people's ability to access care and the kinds of things that they need, and are really important pieces of information for a clinician or for an enabling services worker to have when they're creating a plan that works for the patient and appropriately addressing their needs to give them care that makes sense. So these are just a few examples, and we can go into them more at a different time, but that's also showing up in the EBS. And just in terms of kind of broader connection to all sorts of different kinds of access and quality improvement initiatives, I think it's like some 70%, 80% of health centers now are PCMH recognized. There was a big push from CMS to through the Advanced Primary Care Practice Demonstration to get health centers in the patient-centered medical home model, which really pulls at a lot of these different uses of data to do population health, case management support, create care plans that make sense for the patient, have team-based care that includes people providing enabling services such as outreach workers or transportation services. And this is all part of looking at quality care and patient-centered access and continuity to care in ways that make sense for the patient. So it all ties together beautifully. And just as a general overview in terms of stage 3 meaningful use, which is important data to be collected required through health, through high tech, and through the EHR systems, is also tied to the patient-centered medical home model, which uses the Z codes, and also a lot of patient-centered medical homes participate in managed care organizations and accountable care organizations, which are all trying to also improve quality and access and reduce some costs, and try to provide appropriate and connected care in communities through providing some of these non-traditional, like non-clinical services. So it all ties together beautifully. I'm really excited that you're here and the health centers are working on providing enabling services and collecting enabling services data. So with that really broad overview, I will turn this over to Joe at AAPCHO.
Great, thank you so much, Kristina. Can you hear me okay?
You sound great.
Great, fabulous. Hello, everyone. Thank you so much for joining us for today's webinar. As mentioned earlier, my name is Joe Lee from AAPCHO, and I'm really excited, first of all, to see the diversity of workforce that we have among the attendees from health centers and primary care associations and health center control networks. So I just want to welcome all of you, and also just give a special shout out to all the enabling services providers. I see some community health workers on the line here, as well as folks who might be interested in starting or expanding their data collection initiatives for STOH and enabling services. So I'm talking to all the folks who are working in IT and informatics and whatnot. So thank you again for joining. I just want to kick off this section just first by saying that I think all the participants here on today's call, or one of your colleagues, can tell a great story on how one of the enabling services that Kristina has mentioned earlier has really helped increase access to care for your patient population, and maybe even helped improve health outcomes for your patients. So for example, as an enabling service, we know that case management is associated with improving access to care for those with chronic conditions. And we know that they're important because they're foundational to, as Kristina mentioned, CQI, practice transformation, and so forth. So in this next section, I'll be sharing with the audience today on how a standardized data collection initiative for enabling services can further humanize enabling services at your health center and help you with any advocacy efforts to sustain and expand on critical enabling services. Next slide, please. So before talking about data collection, I'd like to provide a little background as to why AAPCHO pursued the development of a standardized data system to track enabling services. So we often hear from health centers about the problem of having very little data available about the impact of enabling services on quality improvement and health outcomes among medically underserved populations. And this is mainly because the value of enabling services has not been demonstrated by existing data. And we also have another major factor, and the fact is that enabling services have not been reimbursed or adequately funded by payers. So to solve for these issues, AAPCHO launched a project a little while back in 2007 called the Enabling Services Accountability Project. And this was an amazing collaborative effort between AAPCHO and 4 FQHCs, Waianae Coast Comprehensive Health Center and Kalihi Palama Health Center, both in Hawaii, International Community Health Services in Washington, and Charles B. Wong Community Health Center in New York. And the purpose of this project was to fill the information gap by developing an enabling services data collection model for health centers and examine the impact of enabling services utilization on national quality measures. So here in front of you on your screen, you'll see that at the time, we looked at 9 enabling services measures, like case management, financial counseling, outreach, and so forth. And we looked at 2 performance measures, including adult diabetes and childhood immunization. Next slide, please. So the results from this project was pretty exciting. The results indicated that enabling services utilization is associated with better diabetes outcomes, as demonstrated by this bar chart that compares enabling services users in the dark blue and non-users in the light blue. So for us, this project demonstrated the vital role of enabling services in reducing health disparities and improving health services quality. And also what we learned from this project is that having success in tracking good data on enabling services can help you demonstrate what is causing positive change for your patients with specific chronic conditions. Next slide, please. We also analyzed some recent UDS data and found that enabling services are a vital investment in preventive care. Here you'll see that we compared the top 10% of health centers that spend the most on enabling services across the country, and we compared them to the rest of the health centers across the nation. And this bar chart illustrates that enabling services staffing and costs are associated with better national quality measures, including higher rate of diabetes, controlled diabetes, higher rate of controlled hypertension, higher cervical cancer screening rate, and higher childhood immunization rate. So for us, these data findings are exciting, and it really illustrates the importance of how we need to develop long-term regional, state, and federal initiatives to fully support these essential and currently poorly reimbursed services at health centers. Next slide, please. So earlier, I showed you the 9 ES or enabling services measures that we started out with the Enabling Services Accountability Project, and I'm listing them here again on the left-hand side, the left column. And I'm excited to announce that as of 2017, we expanded the set of standardized enabling services categories and definitions to 15 categories. You'll see that you won't see the whole list of 15 categories here. I'll show you the next slide in just a moment to show you the rest. So to give you a quick background on how we went about this process, in the spring of 2016, AAPCHO partnered with health outreach partners and the National Healthcare for the Homeless Council, and we worked with an advisory group of health center representatives engaged in their own enabling services data collection efforts to expand on the original 9 categories in order to really just fully reflect the types of services they routinely provide. We saw that, and we hope that the expanded set of 15 major enabling services categories and definitions will help better capture services currently provided by health centers. On the right-hand side, you'll notice some codes, and we have a frequently asked question in terms of how the enabling services codes provided in our toolkit were developed. And in the beginning, we developed the codes with our member health centers within AAPCHO, but later incorporated wider national input. So what we did was we conducted an environmental scan and interviews with sites to come up with a uniform set of categories across all sites. And I want to point out that the UDS provides some definitions, but the health centers chose to develop categories that were, 1, meaningful to them, 2, it captured the majority of the additional services they provide. And 3, they chose categories that would not be burdensome to implement. We also, I want to let folks know that we also built on a modified set of categories that were developed through a project conducted by the MGMA Center for Research, and that examined a method for coding and assigning relative value units for reimbursement of enabling services. And in the updated version of the enabling services codes that incorporated more of the social interventions, we did have a larger group of stakeholders to help us inform these categories, including NAC, Healthcare for the Homeless, and Health Outreach Partners. So next slide, please. This is the rest of the 15 revised categories and the associated codes. And there was a question asked if folks will be sent the slides, and yes, we'll be sending out these slides, so you'll have a list of these codes available for you. Next slide, please. So I just want to give you here a preview of some just really fun success stories for health centers that have committed to data collection initiatives for enabling services. So from starting in Hawaii, Waianae Coast Comprehensive Health Services, they actually used enabling services data to support reduction in ER utilization, and they received better funding from local health plans by submitting ES data. At Lifelong Medical Care in California, that's the health center where I actually worked at, we tracked enabling services for non-patients to sustain or expand health education programs that we were offering in the community, like walking groups, Zumba classes, cooking classes. And it was great that we were tracking non-patients because of these classes and programs, we were able to facilitate their access to care for primary care services and behavioral health care services. And we were able to have that continuity in data tracking once it became an official patient at Lifelong. In Colorado, Valley-wide health systems had a great success with working with their Colorado Medicaid office to establish a per member per month or PMPM arrangement for care to fund for care coordination staff. And in New York, at the Charles B. Wang Community Health Center, they were able to use enabling services data to reallocate resources to hire for more care coordinators or care managers. And this also led to more Medicaid eligibility assistance for enrollment and eligibility support because they found that this was a critical need in their workforce. Next slide, please. On this slide, you'll see a preview of our documentation criteria, which provides you information on how an enabling service encounter should be documented. So you'll see things like a valid entry would entail that the service must be provided by a staff member or volunteer of your health center. They must be linked to a medical patient, and even a non-patient is fine, as I mentioned earlier as an example. And services must be provided directly to the patient or to their primary caregiver, like a parent or guardian, or on behalf of the patient if this is a referral. So let's see. And for services that, and the services must last 10 minutes or greater, we're recommending that for services that last less than 10 minutes, we do not encourage documentation. For those services that are longer than 10 minutes to document them in 10-minute increments, and also to calculate time increments that fall between 10-minute increments, and any amount ending in less than or equal to 4 round down, and all amounts ending in 5 or more round up to the nearest 10 minutes. So this is very technical in terms of documentation processes and procedures. But we're happy to provide more information on this if you're interested. Let's see. One of our health centers in the past asked why we're encouraging 10-minute increments. This was established by our data standardization process and with our stakeholder feedback. We do encourage you to survey your staff and ask, on average, how often do you provide services in less than 10 minutes? Is it always? Is it most of the time? Is it some of the time, or rarely, or never? So this could change our documentation standardization processes in the future if we do see that there are services provided in less than 10 minutes. So to wrap up this section, I'd like to share that there are so many benefits of having standardized data, and that health centers recognize that enabling services do play an important role in the health of your patients, and that collecting this data would really enable you to better understand, health centers to better understand the nature of enabling services, like the volume and time spent on enabling services and how they affect healthcare. And there's also great opportunity to advocate for funding and reimbursement, just like how what Michelle mentioned earlier with SDOH data collection. So this concludes my section on how health centers can humanize enabling services and advocate for them through data collection. Thank you. And I'll turn it back over to Michelle.
Great, thanks, Joe. So another core competency that we think is important for health centers and organizations to have is the health information technology infrastructure for data collection. And this is both for social risk data collection and then also for enabling services data collection. Next slide, please. So this is an example of the Prepare electronic health record template. So again, we have these freely available. If you go to the Prepare website and then go to chapter 4 of our toolkit, that is all about the electronic health record templates. And there is a link that can then take you to the portal where then you can access the EHR templates themselves. And these would not have been developed without the help of many of the health center controlled networks out there, and as long as with the vendor partners. So this is the GE Centricity Prepare template, and we just have this as an example just to kind of show you a general layout. Each electronic health record template is different, but generally Prepare is there as a form. Sometimes it might be broken up according to some of the categories of social needs. So you might have a socio-demographic section, a money and resources section, and then like a psychosocial asset section that you can kind of see the tabs at the top. But something we wanted to point out is that several of the electronic health record templates automatically map to the ICD-10 Z codes where they exist. So Kristina showed you that table that kind of highlighted some of the Z codes that are available in ICD-10. And we knew it was important to map Prepare to these standardized codification sets to really help promote interoperability, whether it's between different data systems or to really help with aggregation and additional standardization. So we wanted to do that early on. So as you can see with the red circle kind of highlighting with our education question, depending on the response choice that is selected, the Z code will pop up, which gives you the option to add it to your problem list or your diagnostic list. Know that you don't have to put the Z codes on your problem or diagnostic list, because we know there's some people that have preferences one way or the other, or some people don't feel comfortable having the Z codes on the problem list if they feel individually responsible for it. But we think it's important to kind of have that extra layer of standardization, even if it's just on the back end. So we have that option to add the Z codes. You can also see towards the bottom, there are additional Z codes. So they added one for the housing and other problems relating to housing economic circumstances. So this template is thanks to the Alliance of Chicago, so a health center controlled network that really helped develop this. And then they tested it with Siouxland Community Health Centers. And something that's interesting about this template is that then how Prepare is structured, you can see at the bottom with the other red circle, it then it really facilitates the data collection for enabling services as well. So if you go to the next slide, I will turn it back over to Joe really quick just to kind of walk through the enabling services EHR templates.
Thank you, Michelle. So this is an example of an enabling services template from the Charles B. Wang Community Health Center located in New York. And I just want to, the point I'd like to make here is that EHR enabling services templates are available for 4 EHR vendors, including GE Centricity, ECW, NextGen, and Epic. And if sites need or want to create their own template, we just encourage you to monitor and ensure that the response items are as standardized as possible. On the screen in front of you, you'll see a screenshot of Charles B. Wong's EHR template for enabling services data collection. And you'll see a description on the right-hand side where their social work department, they conducted assessments to assess the social determinants for every patient who was referred to the social work department for services. And they had an enabling service taxonomy to capture the services delivered at the end of every encounter. From this enabling services data collection initiative, they were able to measure that in 2017, they delivered over 22,000 units of enabling services for approximately 11,000 patients. And you can see, I'm not going to read these out here in detail, but you can see some of the top 3 enabling services identified for the patients that they've collected data on. So just want to provide you an example of this for EHRs, for enabling services. Thank you, Michelle.
Great. Perfect. Thank you. So how do these 2 data sets really work together to transform care? So it first starts with the community context, which you guys are all very familiar with. That's where you're rooted in terms of your communities and understanding your communities. But then when you start collecting standardized data on the socioeconomic circumstances of your patients using Prepare or other tools, then you're really starting to understand and documenting those root causes that are making patients more complex. Then if you take it to the next level and you start to transform care based on the needs and you're documenting what you're doing using the Enabling Services Accountability Project and documentation, then that can really help you think through how else can you transform care. Maybe do you need to provide additional enabling services, or are there ways that you can enhance your enabling services? Are there new community partnerships that you can start forming based off of the 2 data sets with Prepare and then with the Enabling Services Accountability Project? This can all really help inform better care management because you're figuring out what is working best with your patient population and with your own workflow and your staff and resources as well. As you're transforming care, hopefully that will lead to impact in terms of lower total cost of care. If you're helping prevent avoidable hospitalizations or ED utilization, hopefully it will be improving outcomes in the long run because, again, we'll all be tackling those upstream root causes of poor health. We'll be establishing a return on investment. So a quick example of this could be that a health center had a large no-show rate, and once they found out using Prepare that it's because 1 in 3 of their patients were experiencing transportation issues, and then they implemented transportation interventions, they had a very quick way to analyze ROI just in terms of reducing their no-show rate, and so how that is bringing in additional money to the health center and improving the outcomes because people are getting the care that they need, and so on. So I know sometimes when we hear ROI, we're thinking something very grand and something that will take a long time to do, but it's also possible to think about what are those smaller scale return on investment that you can help make the business case for doing this work. And then finally, as we're having this impact and we're showing that there are results in doing this kind of work, moving it upstream, focusing on the non-clinical needs, then we can use that to really help with reform and sustainability such that we're really moving towards value-driven care, care that is very integrated, not just within the health system, but with our social service partners as well, such that it's really a community-centered care model. And finally, again, as we've all kind of been emphasizing, we really hope that this helps move the needle towards payment models that incentivize this focus on social determinants of health. But you can't do that without really analyzing the standardized data for that. Thank you. Yeah, you can go to the next slide. Thank you. So again, just a reminder, here are the web links where you can find more information and lots of great free resources for both Prepare and the Enabling Services Implementation Toolkit. And go to the next slide, please. Oh, great. Guess we'll open it for question and answer. Unless Joe, is there anything you wanted to add?
No, I think you covered everything. Thank you.
Okay, hi, my name is Cindy Selmi, and I am the Executive Director at Health Outreach Partners. I want to thank my colleagues for this excellent overview on enabling services data collection and how it affects the social determinants of health and addressing those with our patients. I come from a health center background, and I fully understand that whenever we have a new initiative or are changing our workflow or adding anything to our day-to-day work, that it could be overwhelming. So what's the next step? Well, we at the SDOH Academy are very excited that in 2 weeks from today, we will be having the next webinar in our series to take a deeper dive into how to use these tools and practice and implement them in your health centers. During this time, we'll be having some activities and scenarios where you all can practice and see in use how this will work for your various jobs. And as this slide demonstrates, that really anyone in the health center can have an effect on making transformative changes for our patients. And clinical staff can begin documenting enabling services in the waiting room, and this will walk you through the workflow during our very next session. Next slide. And we will also practice documenting the scenarios that you encounter, as Joe had explained in his session, documenting the patients, why they were there, who was the provider that saw them, what was their title, what was the code for the visit or the enabling services that was discussed, and how much time was put into it. And as participants, you all will get to practice that during our next webinar. So thank you very much for participating today. As we noted in the beginning of our time together, that we will have a evaluation that will come up. We ask you to please take a few minutes to fill that out for us. It's very important. Thank you for being here today. I want to thank my colleagues, Kristina, Joe, Michelle, Darlene, and also to Albert, who was not with us. And here is the registration information for our next session. It is 2 weeks from today, February 26th, at the same time, 2 o'clock Eastern time. After we're done here, we will have office hours for 30 minutes. And we also invite you to contact us and reach out if you had any questions. We're all here as support. And thank you very much.
Thank you so much, Cindy, for that information. Now we're going to transition over to our office hours, and we'll enable everyone to have an opportunity to ask questions. This is a time for you to, I saw we had some questions that had come through during the presentations and and they have been answered in the chat box. But if indeed you have some questions that you would like answer or more clarification, feel free. Danielle, will we be able to unmute, or how will they still need to chat? What's the best way?
Yes, Darlene. Everybody, whoever would like to ask a question, please remember to unmute yourselves and you can speak directly into your microphone.
Great, thank you. So if you have a question that you would like to ask us or you'd like more clarification, please take this time to do so. And I'll also invite our presenters, Michelle, Joe, or Kristina or Cindy, if there's any additional information that perhaps you didn't have a chance to talk about, or you like to additional points that you would like to make sure that our audience knows about, we can take that time now to do so.
Thanks, Darlene. This is Michelle Jester, and I just wanted to make sure Arlene had asked a question as to why gender identity and sexual orientation was not part of Prepare. And so thank you so much for bringing that up. That's a very great observation. When we developed Prepare back in 2013 and 2014, HRSA was still working with Fenway and some other organizations to figure out how best to structure and ask questions related to sexual orientation and gender identity. And so at the time, it was definitely on the table. We discussed it with our stakeholder advisory group. It was a priority to include, but we didn't want to develop questions that would potentially differ from what HRSA and Fenway and that group came up with, and that would ultimately be incorporated into UDS. And so we held off at the moment, but we fully support the collection of that data. We know you guys are doing it as part of UDS, and it is our intention to build it into Prepare 2.0. But we're trying not to release too many Prepare versions, very quickly. And so we have a strategic plan for when there would be a Prepare update for that. So just wanted to bring that clarification. But thank you for raising that question. It was a very good one.
Thank you so much, Michelle, for the explanation. And as I was going through the chat, I did see that there was another question regarding explaining. This was for Joe when you were doing your examples of the different health centers. And I know there was an example or a question regarding, please re-explain the non-patient. So would you like to just share, just in case others did not see that response in the chat?
Absolutely. Thanks, Darlene. So that's a great question. And what I meant by non-patients, and maybe there's a more appropriate term for this, but these are folks who are not yet registered to receive medical, dental, behavioral, or any other kind of service at the health center. So the example I gave earlier, lifelong medical care in California, they tracked enabling services for non-patients. They also call them community members to help sustain or expand health education programs that were both open to registered patients and non-registered patients. So if any of you have recommendations or thoughts around this in terms of tracking data for community members or non-registered patients, please feel free to let us know. We would love to hear your thoughts and your stories. I hope that answered that person's question.
Great, thank you.
Thank you.
Okay, are there any other questions or?
It looks like there's another question. I'm looking through the Q&A box here. There's an app, a Prepare app. Michelle, do you want to answer that if you're still on?
Yeah, I'd like to talk to that the person, Jesus, about that, because I'm not aware of a Prepare app, so I'd like to get a little more information. Maybe it's health centers that are working with an additional vendor to build it into more mobile technology. But yes, to my knowledge, I'm not aware, or if it's the Epic Orchard app. But those are the only two things I can think of for an app. So yes, Jesus, I'd like to connect with you if that's okay, maybe via email to learn a little bit more.
Right. There's another one on Prepare that just came up, Michelle. It's from Gabriella. Would the upcoming Prepare update also include EHR Prepare forms?
Sure. Hi, Gabriella. So yes, and that's why we want to be very thoughtful as to how often Prepare gets updated. And so we are envisioning kind of a not big in the sense that a lot of things are going to change, but more, that this will be kind of like one of the few times that Prepare is updated. So we would add things like SOD data, or just based off of feedback that we've received from the field after it's been out there for a couple of years, other things that people wanted to add or to that nature. But the main update is that it's our hope, and that we are working very closely with AAPCHO on this, is that we could have something that helps really bridge the prepare and the enabling services and expanding the enabling services and social determinant interventions documentation. So that's kind of the big vision for the quote unquote update, because it might include things in terms of how much time did you spend trying to build cross-sector partnerships with the housing agency or things like that. This is something we are still very much in the early stages. I know AAPCHO's already done a fair bit of work doing an environmental scan and talking with people in the field, but that's kind of our plan. But it would involve the EHR prepare forms being updated as well. And Joe, I don't know, Joe, did you want to add anything on that?
No, I think you covered everything, and it looks like I'm not sure if I'm understanding Gabriella's question fully. That's written out in the chat. I think she also asked about EHR prepare forms, and we just want to let folks know that there are EHR templates available for prepare in 6 EHR programs or vendors, or platforms. Sorry, so there's Cerner, Epic, ECW, GE Centricity, and NextGen, and Greenway Intergy recently released a free prepare electronic health record template. So just wanted to provide that clarification, and hopefully that answered your question, Gabriella.
Sure. I think just before I have to jump off to another meeting, Gabriella, I think, yes, the update would also update the EHR forms, if that's what you were also trying to get at. Either one. I think, thanks for the clarification, Joe, but in case you were also asking if the update would include updating the EHR forms, the answer would be yes, that we would work with the vendors to do so. And then I see there's a question from Abby. So how is social determinants of health information collected in primary care shared with hospitals? I think that really varies community to community. I know there are several health information exchanges, community information exchanges that allow that facilitation of data. I think that's still a lot to be figured out as well in terms of who are the shared members across these different organizations. I know, Joe, you might be able to elaborate on this a little bit more, but I know of several health centers, Y&I being one of them, that they have a great relationship with their hospital and their community where they get data from the emergency department such that who of their patients have been going to the emergency department so that they can then do active outreach to those patients and ask some of the prepare questions to see if there was some social barrier that was preventing them from being able to get the care that they needed so that they needed to go to the emergency department. I will say several state health information exchanges are interested in using prepare as the standardized social determinant data infrastructure. Also Medicaid managed cares and health plans are also very interested and are using prepare. So we are seeing prepare extending beyond health centers, which is very exciting, and I think that provides a lot of opportunities to promote collaborations between health centers and these other healthcare entities as well.
Great. Thank you so much, Michelle. Appreciate the responses as well from you, Joe. Appreciate that.
And no problem. And yeah, and thanks, Michelle. And I know Michelle has to jump off, so I'll just to piggyback on her comment from regarding Abby's question. Some of you might be interested in exploring California's whole person care pilots. They invested about $20 million having like a one-time funding opportunity for counties to initiate whole person care pilots where they're trying to basically coordinate all of the health and behavioral health and social services, and as well as collaborating with like law enforcement and community-based organizations and the schools. And they're trying to really have this big data exchange, health information and community health data exchange set up. And as an effort to address all social determinants or social drivers of health of vulnerable populations like those experiencing homelessness and whatnot. So I would encourage you, Gabby Abby, Abby and others to explore that model. And depending on what state you're in, I certainly encourage you to hit up your Department of Health and your Department of Public Health or Health Services, whatever entity you currently work with or could work with in the future to see if there is any opportunity for health information exchange or data exchange among various entities within the healthcare ecosystem and across other different types of organizations that help drive the wellness and health of the populations that you serve.
Great. Those are good suggestions, Joe. Thank you so much for that. Are there any other questions, or you guys are feel free to ask? If you don't want to use a chat, you can also unmute yourself and ask your questions verbally if you would like to do that. I haven't talked to my other presenters, panelists, but we would be open if you want to also give us some insight as far as what you would like us to, if you want some more insight on our next session on the 26th. You can also provide that in the chat or open up your line and tell us that as well. If you're looking for some, particular pieces of information or some specifics about different aspects of our enabling services as we prepare for our meeting session on the 26th of this month. If you want us to make sure that we cover a certain topic, please feel free to put that in the chat, or you can, again, open your line and let us know about that as well.
That's a great suggestion, Darlene. Thank you. Yeah, we would love to hear from folks on the line here. If you're able to, if you or your colleagues are able to make it to the next session happening in 2 weeks, we do our best to tailor our trainings and contents to meet your needs. In addition to what Darlene mentioned, if you don't have any questions, I'm actually curious to hear from some of the folks here on the line if your health center or your primary care association is looking to start or expand on your existing data collection initiatives for STOH and or enabling services. Please feel free to type into the chat where you currently are in terms of, are you at the beginning of your journey? Are you in the middle of your journey? Or do you feel like you have really have a solid data collection initiative or program in place? Please share with us, because we would love to hear from you any worries or existing challenges or best practices or lessons learned, because all of this information is just so helpful for us at AAPCHO, NAC, the Council, and Health Outreach Partners to really figure out ways moving forward how we can provide more tailored training and technical assistance for you all. So if there are any, feel free to type in the chat or in the questions what your experience has been so far, or what you think, what your needs might be moving forward. And certainly don't be shy. We can, keep your responses. We can certainly keep your responses anonymous. Sometimes I'm just projecting my own experience here when I participate.
Right.
Webinar.
Yeah.
I get nervous by like, oh my gosh, how many people are on? Am I going to ask a question that might not be relevant? But I think every question is really important. So we won't bite. So we encourage you to participate.
Well, we can give it a few more minutes, I guess, to give people maybe a couple of more minutes to give them opportunity to share, ask questions, and then if not, we can move forward and prepare.
Great.
Yeah, there's something that just came through. Yeah, go ahead, Joe.
Yeah, Yeah, sorry. It says there's a comment, I think it'll be covered, but would be great to know who is conducting the STH screening and how frequently it gets collected from a patient.
Mm-hmm.
And yes, hospitals in Washington are very interested. We have some innovators starting to integrate STOH in Epic. Great. Yeah, we can, this is something that to whoever typed in that comment about, who is conducting STOH screening. One really important news that I think all health centers and primary care associations should be aware of is that starting for the next UDS, HRSA or the Bureau of Primary Healthcare, they have incorporated a question under the UDS report under the Health Information Technologies Capability section, where health centers will be mandated to respond to a question whether you are currently collecting data, if you're currently screening for social risk factors, and if so, what tool are you using? And Prepare is listed as one of those tools, and some of you may be using other nationally recognized tools like the Accountable Communities Healthcare tool or any others. So we just want to let all the folks know that it's really important to answer that question to the best of your ability and accurately, because that will actually serve as baseline data for our organization, AAPCHO, and for NAC and our partners on the line here to determine, how many health centers are actually conducting these STH screenings, and what will be the training needs moving forward. And I'm glad to hear that in Washington that hospitals are very interested. I think I'm finding this just anecdotally. I'm just hearing this everywhere. Suddenly, STOH is the new trend, the new buzzword among hospitals and major health systems. And just want to acknowledge that I think community clinics and community health centers, we've addressed social determinants of health since the time we were born in the mid 60s. And I think it's really interesting that hospitals are really gaining attention on addressing social determinants or social drivers of health. And there are many opportunities for partnership and collaboration. So thank you for that comment.
And I think that they're asking as far as just who within that system, I guess within the workflow, who actually is collecting that data. And how
yeah.
frequently from that. And I think it also varies, right? I know we hear from different health centers within Healthcare for the Homeless that some have, I know one health center in particular, they have community health workers that screen 2 of the questions off of Prepare, mostly for food security as well as the housing. And if they have those 2 positive screens, then they refer them on for a more in-depth screening. Others have a medical assistant that screens. Some have their front desk. So it's various people that are within the workflow who are screening. And perhaps, Joe, you have some examples as well. And just knowing who in the workflow at the hospital. Some have the social workers that are doing it. Within the hospital system, I know when they're screening for social determinants as well.
Absolutely. Yeah, those are really great examples, Darlene. I wonder, Danielle, could you go back to one of the teaser slides? It shows there's like a screenshot of examples of Prepare workflows, and I'm sorry for misinterpreting that comment. Who is collecting it and what's the frequency? I just want to, for folks who are looking at the screen right now, feel free to take a screenshot of this if you want. We'll also send you a copy of these slides, but these are some workflows that we have seen created by other health centers, by health centers across the nation, where they have used, non-clinical staff like enabling services providers. It could be a community health worker, it could be a health educator. We also found clinical staff like nurses and medical assistants and behavioral health clinicians involved. In terms of frequency, if you look under the when column, we have some health centers who have found it easier to conduct the STOH screening before the provider visit or during the visit before the provider enters the exam room. And so there are just so many different ways. And what's wonderful about these workflows, we call this the 5 rights framework. And I'm not going to give too much information about this now. We really encourage you to come to the next session to learn about the 5 rights framework. We're going to have an activity to help map out, your own workflow that fits your needs, and also that reflects your abilities to be able to do this. There was another comment about validation, data validation, and I'm really glad that got brought up. Whether it's prepare or enabling services, data evaluation and validation. I'm going to just switch over to kind of enabling services data collection for a moment here. One tip that we got from the Waimanalo Health Center in Hawaii, they realized that their enabling services data required periodic data evaluation and validation, and that making sure that that they had a thorough review of what was being collected in their electronic medical records. So some of the tips that they had was to first identify your data elements. So identify all of the discrete data elements that will be helpful for your data validation process. It could be like enabling codes, your service dates or units of time, your enabling service provider. And then we have received a tip from the health center to conduct randomization. So randomly select encounters from your report, ensuring diversity among your enabling services providers. And there are a lot of different tools that are available to help randomize your data, such as Research Randomizer. It's a free random sampling and random assignment program. And you can validate your enabling services by through an Excel report and match the data in the report or services provided with documentation in the patient's medical record. So if you're interested in tips for data validation or the process of about going about it, I encourage you to download the toolkits that were presented earlier for both prepare and enabling services. So thank you for that comment about data collection and data validation.
Great. Thank you. And there's some in the chat box that are just sharing some of the work that they're doing. So they're responding to your question, Joe, when you're asking them just what are they doing. So we appreciate those who are willing to share, telling some of the information that how they're approaching documenting SDOH.
Great, fantastic. All right, we see, great. Yeah, I see the examples in the chat. And that's great. One health center is describing the types of populations they work with. This is really important to first just acknowledge, the types of populations, the vulnerable populations you serve, and being mindful of some unique characteristics of your populations. And I think this presentation really. The driving point here is, with things like prepare or any SDOH screening that you're doing, you can really capture the full socioeconomic picture of your patients, right, individually and just as well as for just your entire population. And we have just seen some really amazing examples, like in Charles B. Wong Community Health Center in New York. They in-house they worked with their data informatics team to basically create this dashboard where they can segment their populations according to the specific boroughs I think, or regions in New York that they live in, and they were able to just really determine like the top 3 social risk factors, for each borough. Is it housing? Is it transportation? So we found that to be really interesting. So prepare or any SDOH screening initiatives can really help you better understand your patient population. It seems like we have a PCA working to expand their prepare screening. They're currently assisting health centers to develop a data strategy and develop pilot interventions for patients' priority social needs. Fabulous. That's really exciting to hear. Please send us your stories, your training efforts. Let us know how we can partner with you to support your work and how we can showcase this work too. for other health centers and PCAs across the nation.
Exactly. Yeah, we encourage you to share because we always want to, lift up what's working. So give us opportunity to do that. Very good. I was going to also mention, Joe, just as we're kind of talking, just giving people opportunity to kind of share and to think about other questions that they may have. And we have found also that it appears that when an organization and their staff are involved in addressing the social needs of their clients and patients, it seems to also decrease the feeling of burnout and compassion fatigue that they may be feeling because they feel that they are able to give some answers and to do something, right? And so when you start developing those partnerships and you start developing those referrals and you start looking at, okay, how can I help beyond just giving a prescription, or even if the prescription's for food, if we're trying to do an initiative around food as medicine or starting a medically tailored food pantry, just being able to have some referrals and some answers to some of these social needs is helping with the issue of burnout and the feeling that I don't know what to do. I have nothing to offer this patient. So
Absolutely.
It is important, both also for the patient, but for the staff and the team within the organization to address the social determinants. It's very important for that.
Absolutely. Absolutely. Couldn't agree with you more. Yeah, we often showcase this one story where in Massachusetts, a health center that's located just really far away. I think they're located east of Boston, I believe, that they're located in a rural area, and they struggled with food insecurity for so long. And because of Prepare, or because of their S2H data collection initiative, they were able to collect data and just really demonstrate the need for the critical issues around food insecurity. And they were able to partner with, and even if they didn't have like a local food bank or farmers market to partner with in their area, they were able to send this data to the food bank in Boston, which was, I think, 70 miles away, if I can recall correctly. And the food bank there, they acknowledged this need, and they ended up arranging a weekly delivery of free, just fruits and vegetables and just anything that the food bank could offer to that health center. So it really helped address that food insecurity issue, thanks to the partnership that was formed, because and that partnership was driven by the data presented, that was collected and presented. So there's some just really inspiring stories that you can inspiring stories out there that we have seen the enormous impact, the positive impact of data collection, data sharing, and how that can really help add to more resources that your health center may need for your patient population, and resources that maybe you may not be able to create in-house, and maybe resources that are really time intensive, and as Darlene mentioned, it could lead to burnout. Think about the possibilities you can do, and the power of data, how you can use this data to forge new partnerships and partner with outside organizations to help address your needs. We I see another comment about that we could use a glossary of acronyms. I completely agree. I think we all can.
Yes.
That's a great idea.
It is a great idea. We can, and Kristina put in there, we can do that at their next training. So thank you, Jesus, for that suggestion. Well, if there's no more questions or comments, I want to also give Cindy or Kristina an opportunity to say something, or even Danielle, before we sign off, to make sure that we've covered everything and given everyone an opportunity. Is there anything that Kristina or Cindy or Danielle, would you like to say anything before we end this portion of the webinar?
Yeah, this is Danielle. I just would like to remind everyone to fill out the very brief survey that will launch right after this webinar. And as a reminder, the recordings will be available on our website, www.sdohacademy.com. And there's also a lot of really great resources on there as well.
Great. Thank you so much, Danielle. Appreciate that. And I think with that, we will sign off with for our office hours. We want to just encourage you to join us on the 26th of this month for a deeper dive, and you see part of the teaser of what we'll be covering. So we look forward to speaking with you and joining with you at that time. Thank you, and have a great remainder of your day.
Thank you.
Thank you. Bye.
Thanks,
Bye.
everyone.